Now, we know that in ASOCT, the irido angle contact is something that can be measured. I think some of the images are not coming. Check. Okay. So the images are not coming. Shall I use my pen drive to present? Or it's okay? I think we'll skip those, whatever is not coming. The images are missing. Anyway, so I think those things we have seen pre-PI and post-PI, how the images, ASOCT angle shows an opening. Some of the high definitions OCTs can even pick up the choroidal effusion or suprachoroidal effusions, as you see in topiramate-induced or drug-induced angle closure. The evolution of OCT has been explained earlier, so I'll just emphasize on the fact that there are certain things that we need to understand, that identification of the scleral spur becomes an important landmark here whenever we are doing anterior segment imaging or ASOCT, because most of our measurements are dependent upon the localization of scleral spur and then the Schwalbe's line. So there are certain quantitative analyses that can be done using these parameters or these landmarks. And now with the advent of SSOCT, you can actually have multiple scans which can give you something closer to the gonioscopy. That means gives you multiple scans and give you an idea of how much the angle is closed in terms of different cut section and not only a single section. So this gives you an important index. I think that is also discussed, the irido-trabecular contact index. So you can have a panoramic idea about how much of the area is having a contact so as to understand that how much occludable the angle would be in a given patient. So again, here the landmarks of scleral spur and ITC endpoint are important. Here they are multiple pair of images that are specified, and then it gives you an idea about how much is the irido-trabecular contact. Again, some of the quantitative measurements that can be done by these OCTs is anterior chamber volume, iris volume, anterior angle opening distance, and trabecular iris space area. So you can actually look at the type of angle closure glaucoma, which are the non-pupillary block elements which are responsible for in a given patient. Even the lens vault can be measured. However, for that you have to draw a line joining the two scleral spur and take a perpendicular from the lens anterior surface so as to give you the idea about how the lens vault is. So that can give you the other factors involved in the angle closure. Now, some of the clinical examples. This is a patient who was 10-year-old, so was not sure whether it is CHED or glaucoma. And when you look at the ASOCT picture, I'm sorry, the pictures are not coming here. So we could figure out that this is Exenfield Rieger anomaly. Bleb issues can also be dealt with looking at the ASOCT. Now this is another example where we had done, patient had undergone trab and trap both eyes and came back with high pressures in both the eyes. And with the use of ASOCT, we could understand that one of the eye had an patent internal ostium, and the second eye, again, images are missing. No, it's not coming here as well. So one of the, I showed that there was a patent internal ostium where we could do the needling. The second I showed that there was a PAS, so we could do the second trap for that patient, and both the eyes could be managed. I don't know whether I should proceed with the, there are no images. Can I use my pen drive?
In the meantime, if somebody has a question, we can take up the question also.
If you could answer, you had a question that in a mob, how do you identify? So there is no, like, you're comparing a torch and cataract. There is nothing like that for glaucoma. I mean, you'll have to check the pressure, you'll have to look at the disc and do a gonioscopy. At least these three things are necessary. That's how.
Like the patient used to come to our OPD and suspected glaucoma to that patient. We have to look after for these three modalities which you have done. One is IOP, other is discrimination, and third is
Gonioscopy. Yeah. But beyond, if you don't use these three, you cannot identify a glaucoma patient. So if you have to, if a patient walks into your OPD, even it's a huge OPD with huge numbers, if you have to identify also glaucoma, you have to do these three things. Only then you can identify, okay, this person has glaucoma. This is the basic minimum. There are others also, but this is the basic minimum which you will have to do.
The perimetry also comes in basic
For the
minimum actually.
for the good, now there is an emphasis on the good screening in the large population, and for that the tonometry, you can carry the pneumotonometer along with you, and it can does a good mass screening. For the angle closer glaucoma, you can do a good flashlight test, and obviously, like you do a diabetic retinopathy screening, you can do the optic nerve head evaluation with that. So this makes a sense, and you can do with this. And if you suspect anyone has a glaucoma or suspected to be having a glaucoma, then you can bring to the base hospital and do a all thorough investigation and treat him accordingly. Yeah, please go ahead.
Yeah, so I was showing you about a patient who had a PAS, so we know that this is not going to succeed, so we had to do another trab and could identify the trap location better. This is another patient who had a raised intraocular pressure after trabeculectomy. He had a secondary glaucoma post collagen cross-linking. So you can actually see a contact lens there. So he's a contact lens user and had been using a contact lens after trabeculectomy as well. Now, when we looked at the patient with the contact lens on, because his pressures were constantly high, we could see that there is a patent internal ostium, so that is quite fine. And there is a gap between the contact lens and the area of the bleb. But when we looked at the area which is cutting at the bleb and looked at the OCT there, you could see what is happening. So this was the edge of the contact lens which was indenting the external ostium, thereby inhibiting the infiltration of the, filtration of the aqueous and causing the high pressure. So looking at that, we could actually change the vault of the contact lens, and again when we change the vault of the contact lens, and we can look at, you can see how the compression has been overcome, and by just changing that we could achieve the pressure or this bleb to function. So some of the things that can be really achieved by looking at this, you can even have a contact lens which has a notch which can be used so that the bleb area can be avoided for compression. So this is a good way to look at how the contact lens affects after trabeculectomy if the patient has to use it. Talking about UBM now, here again you can qualitatively and quantitatively measure the anterior angle opening distance. I will skip through those routine things that we already know, that how to look at the open and the closed angle, and will take you through certain cases. This is one of the cases had suprachoroidal effusion, again discussed already. Plateau iris is also something that can be picked up very nicely by UBM by looking at the angulation and the absent ciliary sulcus and convex configuration of the iris. This is one interesting buphthalmos case where the cornea was opaque and we were not sure whether it is CHED or buphthalmos, but by UBM you can look at that there was a break in the descemetes, and that was what was causing the corneal edema or the high drops kind of a picture. So it was due to a DM split due to buphthalmos. This is another child where we could use UBM very interestingly. You can see one eye is buphthalmic, that is the left eye. The pressures in the left eye were very high. And there was a very shallow anterior chamber. This is the handheld slit lamp picture from the outside with the phone camera. And you could see that right eye was fine, but the left eye had almost a shallow AC. Now, when we did ultrasound, everything was fine, but interestingly on A scan, the left eye showed an anterior chamber depth of 3.25, whereas we could see on slit lamp the anterior chamber was very shallow. Well, UBM came to rescue. If you look at, this was the lens of the patient, this was the cornea, and this was the anterior chamber depth, that was the A scan that was picking up. And this was a membrane, pupillary membrane in the center along with the iris, which was causing the lens anterior chamber to be shallow. So this was the anterior chamber depth on A scan, and this is what we were picking up clinically. So UBM could tell us that this is not the angle closure due to the lens push or something behind, but it was a pupillary membrane causing the secondary angle closure, which could be taken care of then. Similarly, when you have to do PKP and the cornea is opaque, you need to understand what is the prognosis of the case. UBM comes handy to tell you what is the extent of peripheral anterior synechiae. Another interesting case where we had emid valve implant, and after a year or so the child started developing high pressures. This is how the bleb looked like. And interestingly, we could do UBM over the bleb, like how you put a cup over the center of the cornea. We could ask the child to look in that direction, and we could put a cup on the bleb, and we could get this UBM image to see that there was a thick fibrotic capsule around the valve body, and there was fluid around that between the fibrotic capsule and body of the valve. So we could do a fibrous capsule excision and could revive the same bleb. We did not have to, the same valve could function for this child, and he did well after. We have almost 1 year follow-up now post fibrotic capsule excision.
Sushma, could you?
Yeah, so I think these are the things that I would want to highlight: causes of hypotony, disorganized anterior chambers, trauma situation where you can see the recession very clearly, and lesions which are behind the iris like cyst and tumors that can be picked up by anterior segment UBM and anterior segment OCT, and give us better management plan. So there are good diagnostic tools in certain situations, and definitely the technology is evolving, and we are getting into more and more objective into these qualitative and quantitative analysis.